nipple discharge, sanguinous, 2 centimeter underlying mass, no axillary node. So,
clinical diagnosis in rectal papilloma.
do you agree, Dr. Kalunga?
Yes, Dr. I agree. It's in the rectal papilloma.
All Tondo side, all intraductal papilloma? All? How about Zamboanga side? Do you all agree with the intraductal papilloma, Maya?
Yes, Dr. I all agree with the diagnosis of intraductal papilloma.
Did you hear the presence of a 2 centimeter underlying mass, Maya?
Yes.
So in the presence of a 2 centimeter underlying mass, sanguinous nipple discharge, what should be the clinical diagnosis? So,
Actually, there is a 2 cm underlying mass. My clinical diagnosis should be breast shape.
okay, so the rest of the group here is changing the diagnosis. How about Zamboanga? Joseph?
The patient presented with the nipple discharge of the papilloma mass, then carcinoma will be considered as this patient rather than the benign lesion.
Okay, about this patient. 45-year-old female, married with left nipple discharge, sanguinous, no underlying mass. Hidden.
I'm still considering intraductal papilloma. Intraductal papilloma may or may not present with a mass.
What do you mean may or may not present with the mass? So are you saying now that in the other patient who presented with the mass, you're still sticking to your diagnosis of intraductal papilloma hidden?
Yes, doctor.
Okay, how about Joseph, would you like to react to that?
I disagree with the statement of Angel that intraductal papilloma will present without mass. If there is no mass, then intraductal papilloma should be considered. But if there is already a mass, the malignancy should be considered on this patient.
So do we, and then do you agree with Joseph?
Yes, doctor. If there is a mass, 4 months we should consider birthday, doctor.
Okay, I hope everything's clear regarding the presence of nipple discharge which is sanguinous. The presence or absence of the mass will change the diagnosis. The absence of the mass, intraductal papilloma. The presence of the mass, consider breast cancer. Okay, another patient, 40-year-old female, married with nipple erosion, no underlying mass, no axillary node. Dr. Burgos?
Pagets disease.
What will be the treatment for this particular patient, Dr. Boa?
The treatment of choice here would be MRI.
Another patient, 30-year-old female, married with nipple erosions on both breast, right and left nipple erosions, no underlying mass, no axillary node. So,
Nipple erosion, consider Pagets disease.
do you agree, Dr.
It's a little bit, we have to, we don't consider Pagets disease. Therefore, the first, the benign or the inflammatory condition of this case, I will consider first like dermatitis from this because of the erosion occurred on both breasts, it is unusual for malignant lesions to present like that. It's more inflammation of that I'm thinking of.
Okay? So once you have bilateral nipple erosions or changes, the first consideration is some skin lesions or dermatological lesions of the nipple. Although at the back of your mind, you must consider the possibility of Paget's disease in the rare cases. Okay? But if there's a unilateral nipple erosion, you start strongly considering Paget's disease. Now, another patient, 25-year-old female, married. The right breast is 5 times larger than the left. No breast mass, no axillary node. Richard? Any disagreement from Zamboanga? Minden?
We're considering it after mammomegaly.
Richard?
I agree.
So, why mammomegaly, Richard?
Since there is no mass, it's only an enlarged breast mass on the right, and there's no mass or negative axillary node. I would tend to incline to be more on mammomegaly rather than a cystosarcoma pilotis, which should be had as a cystic and a hard component masses.
So what will be the treatment for a symptomatic mammomegaly? Dr. Boa?
The treatment of choice here for mammomegaly is reduction mammoplasty.
Suppose the patient is asymptomatic. Perhaps.
If the patient is asymptomatic, then we would give her the choice. But the patient will ask for a surgical treatment on this case, then we would resort to surgery. But if the patient is asymptomatic and is contented with her breast, then that will be her choice.
Okay, another patient, 50-year-old female, married, right breast mass, 3 cm, slightly tender, not hard, indentable, with well-defined border, no axillary node. Next.
My consideration is a macrosis.
Any disagreement from Zamboanga? Dr. Jaganahan?
Doc, I agree with the clinical diagnosis of macrosis.
What will be the next treatment? Next step in the management? Jan?
Needle aspiration.
Now, suppose you get 3 cc of yellowish fluid, and then the mass completely disappeared, but 2 years after the mass occurred, what will you do, Jan?
Still, I would try another needle aspiration. Then, after that, if there's still a recurrence, we'll do a excision of that mass.
So you will do an excision after a recurrence after the second aspiration, then?
Yes, Doc.
Why?
Because the treatment of macrosis is aspiration, and if there's recurrence occur, and then you proceed for excision of that mass.
Let's say 2 years after the mass occurred and then you re-aspirated, and you still get the same type of fluid, yellowish, greenish fluid, the mass disappeared. But a year after the mass recurred, So you would operate this time, right?
Yes, Doc.
What's your diagnosis after the second aspiration?
Still macrosis.
So, what made you decide to operate?
Because of the recurrence of that mass.
Any other opinion, Rex?
I think I would prefer to aspirate once more, and then if it recurs back, I would give the option to the patient if she wanted it to be resected. But personally, if I would be the attending physician of this patient, I would rather offer a repeat the aspiration of the said mass.
Would you like to react to that, John?
I will agree with you, Doc.
So you won't operate anymore, just convince your patient for a repeat aspiration.
I agree with I will let the patient decide if she wants excision or continue aspiration.
Okay, let me give you another scenario. On the second time that you aspirated this mass,